Welcome to this virtual briefing titled Older Adult Nutrition Security Next Steps for Congress. This briefing is presented in collaboration with the Academy of Nutrition and Dietetics, the American Society for Parenteral and Enteral Nutrition, Defeat Malnutrition Today, and the Healthcare Nutrition Council. I am Barrett Doctor, Associate Director of the Healthcare Nutrition Council, or HNC, and I will be your moderator today. HNC is an organization representing the manufacturers of nutrition support products, specifically enteral nutrition formulas, parenteral nutrition solutions, supplies, and equipment. HNC member companies are committed to improving health by advancing policies that address and raise awareness of nutrition and its impact on patient outcomes and healthcare costs. This includes promoting nutritional screenings, diagnoses, assessments, and appropriate and timely clinical nutrition interventions while maintaining patients' access to specialized nutrition support products and services throughout their continuum of care. If you need technical assistance during the virtual briefing, please call the number on your screen. Please ask questions in the chat box. This briefing is being recorded and will be made available by the associations on their respective websites. You can also contact me at bdoctor@healthcarenutrition.org. Our objectives today are to identify food security and access to nutrition care challenges for adults and older adults, describe the nutrition considerations for patients with COVID-19 and lessons from hospitalization and recovery, recognize programs to address malnutrition and adaptations made during this pandemic, and lastly, discuss the importance of nutrition and health, key legislation to improve patient access to food and nutrition services, and steps Congress can take to include nutrition provisions in future legislation. As background, COVID-19 presents nutrition challenges for hospitalized patients. Those who require ventilation due to breathing challenges are unable to eat normally by mouth and may require tube feedings. Internationally, there were supply chain challenges at the early part of the pandemic to meet the needs of the demand of feeding pumps and tubes. Unfortunately, many experience malnutrition, which impacts their healing. COVID-19 has presented several other food security challenges we will discuss today. Our goal for the briefing today is for participants to understand the relationship with food and nutrition, the impact it has on hospitalized patients and those in the community, and to remember to put nutrition as a focus in future legislation. A few bills of relevance that we will discuss today include the Medical Nutrition Therapy Act of 2021, which expands Medicare Part B for patients to access registered dietitian nutritionists to receive medical nutrition therapy services for a variety of chronic conditions. The Medical Nutrition Equity Act provides health insurance coverage for medically necessary food for digestive and inherited metabolic disorders. And the Older Americans Act provides services and programs for older adults to reduce hunger and food insecurity, among other benefits. These bills provide benefits for patients to access nutrition services through medical nutrition therapy counseling, congregate dining, and other nutrition services, and access to products they may require due to their condition. We are pleased to welcome Senator Susan Collins today to contribute to this important dialogue. A native of Caribou, Maine, Senator Collins has earned a national reputation as an effective legislator who works across party lines to solve problems and deliver results for the people of Maine and America. For the past 8 consecutive years, Senator Collins has ranked as the most bipartisan member of the U.S. Senate by Lugar Center and Georgetown University. Senator Collins is the 11th most senior member of the Senate and the most senior Republican woman. She is a senior member of the Appropriations Committee and the ranking member of the Transportation and Housing Appropriations Subcommittee. She is also a member of the Aging Committee, the Intelligence Committee, and the Health, Education, Labor, and Pensions Committee. While chairman of the Senate Aging Committee from 2015 to 2021, Senator Collins held 74 hearings on issues important to older Americans. In particular, progress has been made in advancing biomedical research, developing means to enable more Americans to age at home, and calling attention to the growing economic needs of seniors during retirement. Known for her main work ethic, Senator Collins has cast more than 7,800 consecutive votes and holds the longest performing voting record in the history of the U.S. Senate. Please welcome Senator Collins.
Welcome to this important discussion. My thanks to all of you for joining together to focus on older adult nutrition, especially during this pandemic. From promoting disease prevention and management to addressing food insecurity, Academy members and nutrition advocates are committed to improving the health of our older adults. I have met with members of the Maine Academy, and I so appreciate the science-based information and insight of these dedicated professionals. As a senator representing the oldest state in the nation, and as a member of the Senate Aging Committee, I've been a long-standing champion of your mission. I recently led the reauthorization of the Older Americans Act. It was signed into law last year. This landmark legislation increases resources for programs that help seniors remain healthy and age at home. This includes critical services like Meals on Wheels. To meet the needs of millions of seniors during the pandemic, I wrote a provision in the CARES Act to increase flexibilities for area agencies on aging so that they could continue to serve seniors. This included allowing funding for congregate meals to be transferred to home-delivered meals without prior approval. It also included expanding the definition of homebound for the purpose of receiving home-delivered meals to include older adults who are social distancing. Most recently, I helped to secure $175 million for OAA nutritional services in the bipartisan COVID relief bill last December. I will continue to work to ensure that Congress provides robust funding for the most effective nutrition programs. In addition, I've introduced a bipartisan bill with Senator Peters to expand Medicare beneficiaries' access to medical nutrition therapy. This is a cost-effective and proven treatment for obesity, diabetes, and other chronic conditions. I very much appreciate the Academy's support for our effort. From infants to seniors, good nutrition is a vital part of wellness and of preventing and treating disease. I am proud to partner with organizations like yours to serve our nation's seniors, and I commend you for your commitment to improving our nation's health. Have a great discussion.
Thank you, Senator Collins. Next, I will introduce our speakers today. Kevin Sauer is a registered dietitian nutritionist and the 2021 to 2022 president of the Academy of Nutrition and Dietetics. He is also a professor in the Department of Food, Nutrition, Dietetics, and Health at Kansas State University and co-director of the National Center for Food Safety Research in Child Nutrition Programs. Sauer specializes in administrative dietetics and has previous experience in healthcare and food and nutrition services, school nutrition, and university dining. His honors includes Kansas State University's Mary Ruth Bedford Distinguished Faculty Award, the K-State Presidential Award for Excellence in Teaching, the Kansas Academy of Nutrition and Dietetics 2015 Distinguished Dietitian of the Year Award, and the Academy's 2019 Mentoring Award and Outstanding Educator Award. Sauer earned bachelor's, master's, and doctoral degrees from Kansas State University. Next, Ainsley Malone is a registered dietitian and works as the clinical practice specialist for the American Society for Parenteral and Enteral Nutrition, or ASPEN, where she works to support clinical practice activities for the organization. In addition, Ainsley is a nutrition support dietitian at Mount Carmel East Hospital in Columbus, Ohio, where she is involved in managing nutrition care for patients requiring enteral and parenteral nutrition. Lastly, Meredith Whitmire is the Policy Director of Defeat Malnutrition Today. She's also the Vice President of Matt Splancato and Associates and the Policy and Advocacy Director for the National Association of Nutrition and Aging Services Programs. In these roles, she provides policy analysis and direction for and advocates on behalf of a wide variety of aging topics, including nutrition, elder justice, and community-based services. Other than employment, there are no other disclosures from each of our speakers today. Please welcome Kevin Sauer.
Thank you, Barrett, for the introduction, and thank you everyone for being with us today. As Barrett said, I'm the 2021-2022 president of the Academy of Nutrition and Dietetics, the world's largest organization of food and nutrition professionals. The Academy represents more than 112,000 registered dietitian nutritionists, nutrition and dietetics technicians registered, and other health and food and nutrition professionals. I'm honored to be speaking with you today about the connections between nutrition security, chronic disease, and COVID-19 in older adults. I want to start by defining nutrition security. You may be familiar with the term food security, which assesses an individual or household's access to adequate food. This term has been used formally for more than 15 years, and much of the research that I'll cite today looks specifically at food security. The term nutrition security, however, takes this concept a step farther and looks not just at access to enough food, but access to sufficient, safe, and nutritious food to meet their dietary needs and food preferences for an active and healthy life. The Academy believes access to nutrition care, including visits with registered dietitian nutritionists, are an important component of nutrition security. Prior to the COVID-19 pandemic, approximately 8.5% of older adults, or 1 in 12, experienced food insecurity during the course of a year. However, even this troubling figure hides stark disparities. Nearly 1 in 3 older adults below the poverty line experience food insecurity, and the rates for Black and Hispanic older adults are double the national average. Preliminary data indicates that food security worsened dramatically in the early days of the COVID-19 pandemic, jumping by as much as 1.5 times their pre-pandemic rates. Nutrition security and chronic disease are intricately linked. Older adults with multiple chronic conditions are more likely to experience food insecurity. This can be because high healthcare costs make it difficult to afford food, or because functional limitations make it difficult to obtain, prepare, and eat. Making matters worse, poor nutrition is, in turn, associated with chronic disease. Older adults experiencing food insecurity, on average, consume fewer calories, less protein, and lower amounts of many vitamins and minerals. Cost is once again a factor, with more than 25% of older adults who experience food insecurity reporting that they skip medications to save money. Chronic disease and nutrition security have also significantly impacted and been impacted by the COVID-19 pandemic. As I'm sure you've heard, individuals with many nutrition-related chronic diseases have fared far worse from COVID-19 infection than healthier adults. Among all adults, obesity is the #2 risk factor for poor COVID-19 outcomes, including hospitalization, ventilator use, and death. Obesity is second only to age, making this pandemic especially deadly for older adults with obesity. Some of the suggested mechanisms between this interaction are an impaired immune function and decreased lung capacity among people with obesity. Diabetes is also associated with worse COVID-19 outcomes, but notably, people with well-controlled diabetes had better outcomes than those with poorly controlled diabetes, pointing to the role of nutrition security and diet quality in preventing sickness and death. Other nutrition-related conditions that have translated to worse COVID-19 outcomes include cancer, chronic kidney disease, heart disease, liver disease, and many more. The COVID-19 public health emergency has also negatively impacted chronic disease and nutrition security. Ainsley Malone will talk later about the impacts of COVID-19 as a disease on the health of individuals, and I'm going to focus on the impacts of the public health emergency as a whole on the older population. Routine medical care has been severely disrupted due to the pandemic, and it may take years before we fully understand how reductions in screening, testing, and in-person visits has impacted the health of older adults. Chronic disease prevention and management programs, like those run by congregate nutrition sites, public health departments, and the Y, were also disrupted, as were other opportunities for older adults to be active and social. Virtual programs and creative adaptations, like shifting activities to lower risk outdoor settings, have helped blunt these impacts, but they can't fully substitute for all the programs that were originally in place to keep older adults happy and healthy. As I discussed previously, the public health emergency also worsened food security. For some seniors, unemployment or other personal or family financial issues squeezed their grocery budget. For others, safety concerns over leaving the house or having visitors or helpers limited their ability to obtain, prepare, and consume nutritious meals. Hopefully, you're beginning to see the myriad of nutrition-related aspects of the COVID-19 pandemic. So next, let's talk briefly about how nutrition programs and interventions can help keep older adults healthy and in their homes, and can also help those who may have been hospitalized for COVID-19 or other reasons regain their strength and prevent readmission. There are many nutrition programs for older adults in every county in the United States. Two of the biggest are congregate nutrition programs and home-delivered nutrition programs. These programs, along with SNAP, help promote nutrition security among older adults, and particularly those with low incomes or disabilities. Meredith Ponder Whitmere will talk more in depth about these programs in a moment. Medical nutrition therapy also helps older adults stay healthy and manage both acute and chronic diseases. Medical nutrition therapy, or MNT, is the formal term for working with a registered dietitian nutritionist or other qualified nutrition professional to manage diseases or conditions through nutrition assessment, diagnosis, intervention, monitoring, and evaluation. Dietitians provide MNT in a wide variety of settings, including both outpatient and in hospitals. In the inpatient hospital setting, registered dietitian nutritionists are an integral part of the patient's care team. We fill significant roles in the hospital, from conducting patient education on diabetes, hypertension, or heart disease, to prescribing appropriate diets for patients, which includes tube feeding and IV nutrition for the most critically ill patients. Ainsley Malone will talk more about nutrition in the hospital setting shortly. In the outpatient setting, MNT is also a part of the clinical guidelines for a wide array of chronic diseases and conditions. Registered dietitian nutritionists are skilled at treating people with multiple chronic conditions. In an ideal world, patients would have access to visits with an RDN in outpatient settings to help manage any conditions they have. And if or when a person is hospitalized, they would also have access to an RDN post-discharge to address their ongoing issues, along with anything that might have occurred as part of their hospitalization. Unfortunately, coverage for outpatient MNT is quite limited. Currently, Medicare Part B only covers MNT for older adults with diabetes or kidney disease. This is a great start, but 20 years after the creation of Medicare Part B MNT benefit, tens of millions of older adults are still left without care for costly nutrition-related diseases. To fix this gap, we have worked with Senators Susan Collins and Gary Peters and Representatives Robin Kelly and Fred Upton to introduce the Medical Nutrition Therapy Act to expand Part B coverage of MNT to the diseases and conditions that you see listed here on the slide. The bill would also allow CMS to include additional diseases in the future based on clinical guidelines, so coverage can keep up with the evidence base. In addition to the obvious benefits this would have on older adults with chronic conditions, there are also health equity implications for providing coverage for diseases like obesity, hypertension, and heart disease that disproportionately impact many racial and ethnic minority communities. And while this bill is focused on Medicare, Many state Medicaid plans and private insurers have modeled their MNT benefits after the Medicare benefit. So we anticipate expansion within Medicare would lead to greater access for younger adults and children as well. Thank you again for being with us today, and I look forward to answering any questions you have during the question and answer segment. Next, I'll turn it over to Ainsley Malone from Aspen to talk more about COVID-19 and the importance of nutrition in the hospital setting.
Thank you, Kevin, for your insightful remarks. My focus is going to be a bit more specific and will center around individuals who need to be hospitalized with COVID. My hope, after you hear what I will share, is that you understand some of the important nutrition issues experienced by those with COVID-19 who require hospitalization. As Barrett mentioned earlier, I am a clinical practice specialist with Aspen. I thought I'd share a bit more about the Aspen organization. The American Society for Parenteral and Enteral Nutrition, or Aspen, is a medical organization whose members are involved in the provision of clinical nutrition therapies, including intravenous nutrition and tube feeding. We are a global community of dietitians, nurses, pharmacists, physicians, scientists, and other health professionals dedicated to improving patient care by advancing the science and practice of clinical nutrition and metabolism. A large proportion of Aspen members provide nutrition care in the hospital and home setting and have been working with COVID patients throughout this pandemic. This is information from the CDC, specifically as of this morning, highlighting the cases of COVID-19 requiring hospitalization since the start of the pandemic. What is notable here is the red-colored section reflects hospitalizations in those 65 years and higher. While current rising hospitalization rates do show increases for younger individuals, approximately a third of older adults are still being hospitalized with COVID. I wanted to provide a bit more detail about those who are hospitalized with COVID, including these important characteristics. The red portion of these circles reflect incidences in older adults. As you can see, older adults have a higher percentage of ICU admission. They are more likely to be placed on a ventilator and more likely to die in the hospital compared to the overall population. I think these are very important distinctions. In general, being in the hospital can lead to issues once discharged, especially if the hospital course is prolonged. These issues post-hospitalization are not specific to COVID and have been well documented both from an acute hospital stay or a stay in the ICU. All of these are more likely to occur following an ICU stay due to the severity of a patient's disease course. Because patients who are hospitalized with COVID-19 have more severe disease, the issues are most likely occurring, including significant impairment in functional status, an inability to resume activities of daily living, which are generally meal preparation, bathing, putting on clothes, etc. Some of these individuals have profound weakness, and many experience what is known as post-hospital syndrome, which is a constellation of symptoms that can lead to overall issues in terms of having to be readmitted to the hospital or risk of mortality within 6 months or 10 months. So these are really significant issues. Many of you may be familiar with malnutrition as an entity occurring in only developing countries due to a lack of nutrition. Unfortunately, this is not uncommon in hospitalized patients. Generally speaking, it is estimated that 1 out of every 3 older adults admitted to the hospital is malnourished. In COVID, the risk of developing malnutrition in the hospital is quite significant due to all of these factors. COVID-19 is a very inflammatory process, and that inflammation can range to moderate to very severe. And this leads to muscle breakdown and high energy utilization, so an opportunity for weight loss. The disease process often leads to profound lack of appetite or anorexia, which can certainly impact intake of nutrients. That, coupled with the disease process, can lead to malnutrition. While these studies are not reflective of COVID-19 patients here in the US, the same malnutrition prevalence is actually likely given the factors I just previously mentioned. These 3 studies show a significant prevalence of malnutrition among COVID-19 patients with a range of anywhere from 42% to 70%. The Italian study identified that 70% of the ICU patients studied were malnourished during their ICU course. Malnutrition can have significant impacts on outcomes, as I will share shortly. Bottom line, malnutrition in patients with COVID-19 is highly prevalent. Aspen has done work with the Agency for Healthcare Research and Quality over the last 10 years describing outcomes in malnourished patients versus those who are not malnourished. This information highlights this work and shows that those who are malnourished are more likely to die during their hospital stay, have longer hospital stays, have 1.5 to 5 times more infections, and have a greater than 3 times higher risk of pressure injuries. Being malnourished in the hospital may lead to these negative outcomes. Knowing the high prevalence of malnutrition in COVID-19, this is actually quite concerning in terms of negative outcomes for these patients. I've described malnutrition in COVID-19 and the potential outcome issues. The goal is to minimize malnutrition and its resultant outcomes, and that requires the intervention of nutrition therapy. These are some of the recommended nutrition therapies for hospitalized patients with COVID-19. Patients who are critically ill in the ICU, we will certainly begin with enteral feeding, and this is a feeding that's provided by feeding tube, and this is typically initiated within the first 48 hours of their ICU stay. In those patients that aren't able to truly tolerate enteral nutrition and are unable to receive adequate amounts, it is recommended to begin early use of what we know as intravenous nutrition or parenteral nutrition. In patients who have been in the ICU who are transferred to the floor, it is important to continue enteral nutrition because it is known that these individuals have difficulty transitioning to an oral diet. Often the use of oral supplements is indicated, as well as the inclusion of a multivitamin, just because patients aren't able to eat adequately enough to receive all of those vitamins that they require. And then in patients that are discharged from the hospital, it's advised to give smaller, more frequent meals, and those meals should contain high calorie and high protein items to really deliver an optimal amount of nutrients as possible. Again, oral nutrition supplements are suggested, as well as the inclusion of a multivitamin. These are some of the key issues that clinicians caring for COVID patients have identified that can be significant contributors to patients becoming malnourished during their hospital course. Shortages in tube feeding formulas and equipment can lead to patients receiving enteral tube feeding that may not be tolerated, and they therefore don't receive the amounts they need, or they need to receive their feedings in a different manner or format and therefore have difficulty tolerating the formulas. The formula and equipment shortages have occurred early on in the course of COVID, and in those hospitals that are facing surges may very well be occurring at this time as well. Treatments and therapies can often impact nutrient intake. High flow oxygen, for example, can lead to challenges in eating. Also, patients who are on ventilators may actually need to be in a turn from face side down to backside on an ongoing basis, which can impact how well patients can be fed. These are issues many of us have seen and try to manage these in these very sick patients, and it's not always easy. There are many challenges in providing adequate nutrition care to COVID patients, either when they have transferred from the ICU or who have not needed ICU care. Patients that are transferred out of the ICU and are in their post-ventilator phase often have swallowing issues, and this has been reported to be as high as 60%. And so that leads to challenges in the types of food and the tolerance of food that these individuals are able to consume. As I mentioned before, profound loss of appetite often occurs. It is imperative to continue enteral feeding in these patients by feeding tube to support what they aren't able to take in on their own. Patients that are on the floor or the ward do experience GI symptoms, especially in their early phases of COVID. They also too experience the anorexia I've described. They oftentimes have a feeling of fullness with just after eating a bit of food, and this makes adequate intake a real challenge. And this is where the 5 to 6 small meals becomes important. And then they often tire very quickly, and that also leads to a challenge in these folks being able to consume all that they need. One of the most significant concerns in patients hospitalized with COVID-19 is what occurs once they leave the hospital. Many of them experience these ongoing issues, including, again, the decreased appetite that is so pervasive, also the early fullness that I mentioned before. Many of these individuals that experienced respiratory failure or significant impairment in oxygenation do have shortness of breath once they leave the hospital, and that really can impact how well an individual can consume their oral foods, and this becomes a real challenge. So when we think about all of these together, this can lead to ongoing weight loss and can continue to contribute to malnutrition continuing or developing if patients aren't malnourished while they are hospitalized. The information on the right-hand side of the slide are resources that Aspen has produced that help individuals who have COVID help to improve their nutrient intake once they are home from the hospital. I'd like to share a patient story from one of my colleagues who works in the home care environment. This was a patient of theirs. This was a 38-year-old female who was admitted to the hospital for COVID-19. She was in respiratory failure, and during her hospital course, she required ICU care and experienced multiple hospital complications. She did receive enteral tube feedings during her hospital course, but was challenged by receiving adequate enteral feeding and often did not receive adequate amounts of energy and protein and other nutrients. Following her ventilatory support, she did fail her swallowing study, and that required continued enteral feeding, including the need to receive enteral feedings at home. So a long-term feeding tube was placed, and she was referred to a home infusion provider, or home enteral provider. Her feeding tube was removed after 2.5 months, and she was discharged at that time from home care services and essentially was fed enterally over that 2.5-month period of time. Her initial weight upon admission to the hospital was 240 pounds, and at discharge, she was 189 pounds when she was admitted to home care. So essentially, she lost 20% of her body weight over her 2-month hospital course. At discharge from her home company, her weight had remained stable during her time of receiving enteral feedings at home. And I think this, the key point with this is that despite being supported at least, partially in the hospital environment, she did experience a significant amount of weight loss. And this is certainly not uncommon. I hope you'll agree that this is quite a compelling patient story. I have a few final thoughts today. Hospital-acquired malnutrition is a major issue in patients with COVID-19 due to all the issues and contributors that I've discussed. COVID-19 patients who require ICU care are presenting with significant disease severity, which certainly impacts their overall course. There are a number of treatment modalities that can impact how well nutrition care is delivered. And I think you'll recognize that we need to really have perseverance in how we provide nutrition care and how we optimize that care. And lastly, ongoing nutritional issues post-hospitalization clearly need to be addressed so that malnutrition can be minimized and treated and our patients continue to do well. With that, I'd like to thank you for the opportunity to participate in today's briefing, and I'd now like to turn things over to Meredith Whitmire.
Hi, everyone, and thank you so much to our previous presenters. I'm very honored to be presenting alongside such folks today. My name is Meredith Whitmire, and I'm the Policy Director for Defeat Malnutrition Today. And I'm going to be talking about nutrition-related policy fundamentals for supporting older adults in the community. So, before we get started, I wanted to tell you a little bit about Defeat Malnutrition Today. We are a coalition of over 100 national, state, and local stakeholders and organizations, including the Academy of Nutrition and Dietetics, Aspen, and the Healthcare Nutrition Council. and other community, aging, nutrition, advocacy, etc. based groups. And we share the goal of achieving the recognition of malnutrition as an indicator of older adult health risks. And we are working to create policy change, both at the regulatory and the legislative levels, on emphasizing screening, detecting, treating, and preventing malnutrition. So today, this presentation, I'm going to give you a quick rundown of some of the federal nutrition programs that older adults use, SNAP, and some of the effects the pandemic has had on it, the Older Americans Act and some of the effects the pandemic has had on it, program examples from the Older Americans Act, and then some thoughts on what future nutrition policy direction should look like. So community-based nutrition programs for older adults. And as I said, I'll be talking about these first two a little bit more in a moment. I wanted to touch on some of the others as well quickly. For example, the Commodity Supplemental Food Program serves older adults with commodities from, this is a USDA program, and it serves older adults with commodities. Then there's the Child and Adult Care Food Program, which serves, as the name implies, both children and older adults in day settings, you know, adult daycare, child daycare, with snacks and meals. And then there's the Senior Farmers Market Nutrition Program, which also serves older adults. It provides money for older adults to buy vegetables, fruits, etc., from farmers markets. So SNAP, the Supplemental Nutrition Assistance Program. I'm sure all of you have heard of SNAP. It provides monthly benefits to low-income households. It's the largest USDA food assistance program, and it serves more than 5 million older adults annually. And because it is mandatory funding and not discretionary funding, it can serve all older adults who are eligible. So it grows with the need. And there's a huge body of evidence showing that SNAP plays a role in improving nutrition security in general throughout the lifespan. So SNAP during the pandemic, there have been, as I'm sure most of you know, many SNAP-related policies during the pandemic from the various rescue bills. The emergency SNAP benefits, you know, additional allotments can go to households that are not already receiving the maximum benefit for households of their size. And all states received waivers to provide this. And the various rescue bills provided funding for these benefits. In addition, many states had applied for and were approved for waivers to streamline application and recertification for SNAP. And all states were also approved by the USDA for SNAP online purchasing plan, which was very exciting and something that, you know, we were very much in favor of, as far as everyone else gets the opportunity to buy their food online. And so folks using SNAP benefits should be able to as well, especially during a pandemic when you're talking about safety concerns. You have older adults who, you know, always may not have been able to leave their home to buy groceries, folks with disabilities. So we really felt that this was a very equitable thing to do. Then you have the Older Americans Act Nutrition Program. And this is served, these meals are more commonly known as Meals on Wheels and congregate meals. So congregate meals are meals served in senior centers. And they are served to folks who are 60 and above. And the program statutorily has 3 intents: to reduce food insecurity, hunger, and malnutrition, enhance socialization, and promote health and well-being. The statute also requires that it provides not only meals, but also nutrition education and counseling and other nutrition services like screening for nutrition risk and malnutrition. So before the pandemic, the program served almost 2.4 million older adults annually. 1.5 million of those were in congregate programs and almost 900,000 in home delivered programs. So that might be a little bit of a surprising breakdown, given that, Meals on Wheels is kind of the more visible aspect of the program, but pre-pandemic, there were a lot of older adults being served through congregate programs. Also, meals must meet 1/3 of the daily recommended DRIs, meaning the dietary guidelines, the recommendations for older adults via the dietary guidelines. Each meal must meet 1/3 of these daily requirements. The Older Americans Act program is funded through discretionary appropriations. So unfortunately, it does not automatically grow with need. So pre-pandemic, there were a lot of folks who needed this program who haven't been able to access it. During the pandemic, the programs have become even more crucial. And as most of you know, almost all congregate nutrition programs had to shut down. Senior centers shut down, community centers were shut down, et cetera. So these programs tended to convert their participants to either receiving home delivered meals, grab and go meals, so folks would come to the senior center, pick up the meal and leave, or some kind of combination. And demand for meals grew drastically. I thought this was some interesting research from Meals on Wheels America. Right after the pandemic started, 89% of home delivered nutrition programs saw an increase in meal requests. Of those, 79% reported that these requests doubled between February and April. And programs were serving, on average, 56% more meals and 22% more older adults in April 2020. And this demand has not stopped. In one of the other hats I wear, I am policy director for the National Association of Nutrition and Aging Services Programs, NANAS. We work pretty closely with Meals on Wheels America and have some overlap in membership. And our members are also still reporting drastic increases in need. So this has not gone away. And not only that, but you have congregate meals programs that are coming back online. So, it's quite the set of issues out there for older adults. So over the course of 2020 through 2021, thank you to Congress. You all appropriated over $1.6 billion in emergency supplemental funding for these programs. So that really helped meet the need. And this money continues to help meet the need. Some of the other policy provisions that really help the Older Americans Act programs, waiver of those DRI requirements. So during the early part of the pandemic, and again recently actually, with various kinds of food shortages, it was hard for these meal programs to keep up with the growing demand. And there's only a few contractors that provide meals for home delivered. So, a lot of people prepare those on site, but some people do rely on those vendors, and vendors couldn't keep up with demand either. And so the nutrition programs really had to get creative and find new sources of funding and food. And so this waiver was very important. And then also, historically, there has been a transfer limit. So congregate meals and home delivered meals come out of two separate buckets of funding. And there's only, you can only transfer so much between the two buckets to meet local need. The transfer authority was waived for this emergency funding, meaning that it could go to where it was needed most, which was home delivered meals, and now is starting to be congregate meals again. I wanted to go through an example, or four examples of some of the aging programs across the country, local and state, and just how exactly they've been adapting to the pandemic. The first one is in Ohio, Wood County Committee on Aging. It's a rural and it's a nonprofit agency. Before the pandemic, it served about 6,500 people annually, which was a significant chunk of the county's older adult population, about 20%. But all volunteers 70 years of age and older were placed on hiatus because they were high risk for catching the virus. So that's been that is not limited to Wood County. That's been a significant problem in general. A lot of volunteers, a lot of folks who work for Meals on Wheels and other nutrition programs are older adults themselves. So there's been a huge gap there in staffing need. Wood County, like many other programs across the country, pivoted to online programming. So they did virtual book clubs and virtual exercise routines and virtual congregate meals where folks took their meals, ate lunch together over Zoom, and those were really popular. One big problem they faced, a lot of home delivered meals these days are funded through Medicaid, Medicaid managed care, and they were unable to receive reimbursement for some of these new recipients, even if the recipients' meals were being funded through Medicaid originally, because the Medicaid funding was contingent on clients receiving on-site services. So in other words, folks experienced, some technical glitches, basically, with funding issues like that. And that had been and continues to be somewhat problematic. Another example, Nevada Senior Services, which is a large adult day agency. I interviewed the program leader, the CEO of Nevada Senior Services, and he said that they were really forced to rethink and re-examine everything they've done. He believes that, COVID in general is a really unique learning opportunity for the networks to rethink service delivery on behalf of older adults. So, that not just in older adults remaining homebound, but who may still be homebound, but older adults in general. And he said the widest lens into the problems that many older adults face is nutrition. So that's the entry point to a lot of these programs. A lot of the services that these programs can provide older adults beyond nutrition. So solving for nutrition security can help solve for other problems as well. Another interesting program, Feed More Western New York. It's a food bank and nutrition agency serving intergenerational families in Buffalo. So their food bank, their Meals on Wheels, and they also serve WIC participants. And so these agencies merged together to form Feed More in December 2019, so right before the pandemic. And it was very interesting talking with them because they really felt uniquely situated to meet the community where they were at, because they provided all of these various services. And many of the older adults they served needed multiple kinds of services prior to the pandemic. And interestingly, there's been a growing trend toward older adults leading grandfamilies. So they are basically parenting their grandchildren or other younger relatives. And so these older adults are also receiving WIC services for their grandchildren. So it's just it's an example of a really comprehensive approach to providing nutrition. And it's something that we're starting to see in other places. But I thought the quote that she gave was really interesting, that they had a 360-degree view of community need. So they were able to see the whole community and serve the whole community. So then there's Massachusetts and their state unit on aging. They used a lot of social media to reach older adults. So last year they launched a quote, #DoACOVIDCheck, social media campaign. And they have a website where folks can access all the food assistance resources in Massachusetts. So last September, they also launched the campaign Be a Nutrition Neighbor during Malnutrition Awareness Week, which is coming up in October. And that campaign focused on malnutrition awareness and prevention. So it's a very popular campaign. And, I personally was very inspired to hear that this, the state in general was coordinating their activities. So it's not just local agencies, it is also state agencies as well. So some key takeaways. More funding is needed for community nutrition services. And that is, that's just key. I mean, as I said earlier, the demand is not going away. Long-term policy needs to include overall increases for Older Americans Act nutrition appropriations and appropriations for CACFP and the commodity program and, Senior Farmers Market, which has a very small amount of funding overall. And excitingly, after I prepared these slides, as you know, things move very fast here in DC. And so this is already starting to happen, boosting SNAP benefits based on an adequate food plan. As most of you have probably heard, the administration has decided to boost SNAP benefits because it rethought the thrifty food plan. And we were very excited to hear that. So in short, nutrition policies necessary for supporting community dwelling older adults during a pandemic are the same as those needed anytime, but just magnified. So, a pandemic really highlights the pre-existing need. Thank you so much, and I'm going to turn this back to Barrett.
Thank you to our speakers for this important information. To summarize, older adults have been greatly impacted by malnutrition and food security challenges as a result of COVID-19. The Medical Nutrition Equity Act, Medical Nutrition Therapy Act, and Older Americans Act provide older adults with nutrition products and services to address their needs. Please support these bills and include nutrition provisions in future legislation as we recover from this pandemic. Next, we will open it up for questions. So please type your questions into the chat box. So I'm going to invite our speakers to answer some questions. Our first one, which is if the slides and recording will be made available. And yes, we will share that after today. Our first question to Ainsley was related to the statistics of older adults that were admitted to the hospital with COVID, especially at the earlier part of the pandemic. And just, I believe it was a CDC reference, but
yes, it's on the CDC website, and I can, I'll copy the link from my slides that I have opened up on my computer, and I'll put it in the chat box. But it's updated weekly, so not only does it give you the age differentiation of actual COVID cases, but it also provided those characteristics that I mentioned in terms of those requiring hospitalization, being placed on the ventilator, and then also mortality data. So I will do that while you're continuing to ask questions.
Great. Thank you, Ainsley. The next question is open to all of our speakers. Certainly the patients that were admitted to the hospital, whether it's through COVID or any other time, if they happen to be malnourished and then they're discharged home with malnutrition, why would the Medical Nutrition Therapy Act benefit those patients? So Ainsley, maybe you want to start. And
yeah. I think this is a really important question. I've worked in this environment for many, many years and working with patients in the hospital setting that become malnourished. And when they're discharged, oftentimes they don't have the ability to see a dietitian and to receive medical nutrition therapy to address their malnutrition. And so this is a huge, this will be a huge benefit in allowing patients to be seen by registered dietitians after they're discharged from the hospital and really address their malnutrition and provide that ongoing medical nutrition therapy, which most providers don't have nutrition expertise. And so there's a real lack. I think this is huge.
And I'll just add on to that, Ainsley, great response. And, There are things to stress here, such as there's no continuity of care available for these patients' nutrition management due to no reimbursement for outpatient MNT for malnutrition. This, of course, increases the risk of readmission and leaves some patients having to manage their tube feedings and other situations on their own as well. So I think those are important points to remember.
Meredith, anything to add?
No, I think they covered it.
Okay. So Meredith, the next question, I believe we can pass to you regarding the Meals on Wheels program that you talked about. The question is if this program, Meals on Wheels and congregate dining, if they provide customized nutrition or customized diets for those patients, they might require reduced sodium or gluten-free, or maybe if they need to monitor carbohydrates. Can you speak to that? You know, if there's custom diets in those programs?
Sure. So it, much like most community programs, does vary by the program. So as I had said, all programs have to provide 1/3 of the DRIs per meal, but the way in which those are presented can vary. Some smaller programs might not have the resources to do more tailored meals, but a lot of programs do provide meals for special diets. Also, importantly, including diets that are kosher, for example, or halal, making sure that folks with other restrictions are able to participate as well.
Great. Well, we don't have any other questions in the chat box. We have a couple more minutes if anyone would like to ask an additional question. And I'll just field one to everyone, all of our speakers. If there was, you had some great takeaways today, but if there was anything else that came to your mind, we can just kind of go around. If there was any one extra point that you want to make sure our listeners learn from today, what would that be? I guess we can start with Ainsley and then Kevin and then Meredith.
Sure. Thanks, Barrett. I just am hopeful that malnutrition continues to be addressed. There have been many issues with malnutrition, as I mentioned in my presentation, and we've known about it for over 40 years. And our hope is that in 20 more years, we won't have the same issues and our patients will not develop the severity of their nutrition status and really have better outcomes as a result.
Yeah, thanks for the opportunity for some closing comments here. As my esteemed colleagues have already underscored, the role of nutrition is so paramount with this current pandemic, and especially our older adults and malnutrition. And on behalf of the Academy, we just remain so firm with our revitalized strategic plan to focus on well-being and prevention, nutrition care and health systems, nutrition security, and food safety and diversity and inclusivity. And so I think you'll agree that we're all headed in the right direction, and the passion and the credentials and the evidence basis of our credentialed practitioners is very, very important in addressing these needs. So thank you again for the opportunity to be here.
Yes, thank you so much. I'm just, I'm really excited to be able to share the, information about these outpatient programs. I think having hospital malnutrition care is so important, but it's also really important to catch these things before they start, before they are a huge problem. And I would say that, it's very important to support these local nutrition programs, because that's where, that is where the good nutrition can begin. And further, that is where the good nutrition can continue after someone is discharged from the hospital or from a rehab, et cetera.
Thanks. We did have one more question, so this will be our final question before we conclude today. So thank you again to our panelists and to the participants. So the question is around provisions for malnutrition risk screening in primary care or before cancer treatment. There are so many people who are malnourished before hospitalization, as we discussed today, and not all older adults qualify for congregate dining, so they might become malnourished at home. So if maybe Ainsley, Kevin, Meredith, if one of you wants to take a crack at that. So the question is around malnutrition risk screening in primary care or before cancer treatment.
I will start, although I think Meredith probably has a better answer for you. But I do know there was a provision in the Older Americans Act just this past year, am I right, Meredith, that does include nutrition screening in the primary care environment, which hasn't been in place before. So I'm not sure where implementation of that is in terms of the process, but that is, to me, a big step in the recognition of potential for malnutrition.
Definitely. It's not quite in the primary care setting. It would be more in those nutrition programs. So folks who are coming to the congregate or home delivered meals. I would say everyone 16 and above is eligible to receive a congregate meal. So there's no income or anything like that limit. So theoretically, folks can get screened for nutrition risk, but I would say that it is very important to consider malnutrition screening in the primary care setting, outpatient setting as well. There's not a lot of standardization of that, and I think that's something we could talk about for the future, continuing to advocate for and work on.
And Kevin, any last comments to add?
I think they covered it very well. Thank you, though.
Okay, wonderful. Well, this concludes our session today. Like I said, the recording will be made available, and we just want to do an extra thanks again to our panelists for their excellent work and presentations today. And we will be sharing the recording after our session. So thank you, everybody, for attending.
Yes, thank you.
Thank you.
Thank you.